the purpose of those conversations that we have here, right, is to instigate curiosity. I can go into look into epidemiology research and look for, venues that we can expand what we do in terms of risk of cancer. But this interface, it has to happen, right? And the interface with everybody here too has to happen. So then we can, collectively kind of, support each other. This is like sisterhood almost. Do we have any questions from the audience before I can start with a few of my own?
My daughters are proponents of taking collagen every day for their skin health. Is that a dumb thing to do?
I would never say that.
So I don't think it's a dumb thing to do. I think the risk of harm is incredibly low. We don't have strong data to actually support collagen intake leading to positive results. Like, we haven't seen that yet, but I think that the risk is so minimal that I don't think it's doing any harm.
Yes.
I agree. I think the way collagen deposits in your breast, that's what Dr. DeSantos showed, like after UTI, is very different compared to collagen that you would take in a capsule form. So I think it is safe.
Thank you. I won't tell them to stop.
No. Did you have a question?
How do you know it's not the antibiotics? How do you tease out that it's a UTI that's actually increasing the risk versus the antibiotic itself that was used to treat the...
Yes, that's a great question. So there's, again, a lot of what we do is drawn from previous research, and we acknowledge gaps and we fill them up, right? So there is actually one scientific publication that says that antibiotics were linked with increased risk of breast cancer. One. And what we read out of that, what that tells me is that maybe it's not the antibiotic itself. Maybe we are looking at somebody that has a persistent infection that the antibiotic is not treating properly. And that persistent infection is driving change to the body that then is increasing cancer development and progression, right? This is exactly what we see in our model. Our model that mimics loss, mutations in the BRCA gene, if we give them antibiotics, their cancer progression is going to be very similar to animals that were not treated at all. What is changing here is, if we leave those animals to kind of let the UTI unfolds on its own. So it's an increased amount of time exposed to the disease. We have our research tells us that there's very specific cells of the breast of a patient, or at least our animal, that has BRCA mutations, that has cancer predisposition abilities. Not all cells of the breast will have that ability. And what we see, so we have markers. We can label those cells and then go into the breast of those animals that have UTIs and see if those cells are altered. And what we see is that just after 2 weeks of those animals having UTIs, those cells go from like being 5 in breast in general, just 5, to like thousands, right? And it has to do with the collagen, because we can then give those animals treatments that are then cleaving the collagen that they have in the breast. And if you do that, then the cancer cells go back to being 5 again. It doesn't take away the normal risk that those animals would have, because they're predisposed to have that disease, but it decreases the onset of the disease. It goes back to be around the age of, approximately 60 years old in women, than instead of being at the age of 40.
Dr. DeSantos, I have a question.
Yeah.
Does that risk generalize to other types of infection, or perhaps Dr. Sharma knows that answer? Like, I'm thinking inflammation in a general sense.
That's a great question. So we are, I think as a scientist, there's always a fine line between, establishing a strong research portfolio that has trust, but also we have to diversify, and this is at the stage that we are right now. So we are considering fibromyalgia. There are animal models that we can induce fibromyalgia. would they have a different risk? Autoimmune disease, from the opposite, actually, direction, women that have lupus has a decreased risk to develop breast cancer. And we don't know why. Are we here missing an opportunity to look at self-produced antibodies that could be then decreasing the risk? Arthritis, women at the age of 40 and plus develop at a higher risk
Because of menopause.
because of our
The
fat
lack of
patty.
estrogen.
Yes, lack of estrogen. But those are different, right? So it's an infection versus inflammation. I think that other infections of the reproductive system would be interesting to study, like candidiasis, right? Very common. It has even been linked with social determinants of cancer risk because, countries that have of lower income population, women there are developing those type of disease more often. So the longer answer to your question is yes. I think that this opened our eyes to, like Sue was saying, the aha moment. This opened to our eyes to other things that we are experiencing. We haven't been linked yet.
So I wanted to comment because I have one important agenda anytime I have an audience, which is not financially related, it is related to your health of women. I found that aspect fascinating because one of the things that I like to educate all women on is vaginal estrogen and the importance of vaginal estrogen. So after menopause, when our vulva and vagina loses estrogen, there's major changes, including the pH and the vaginal microbiome. And that increases the risk of UTIs significantly. And especially that gets worse. That's one of the sort of menopause symptoms, not really a symptom, it's a change, but gets worse over time. And so we see, elderly women dying or even younger women dying of urosepsis. And there are studies that show vaginal estrogen can decrease the risk of UTIs anywhere from 50% to, there was one study that showed 11 out of 12 UTIs were prevented for patients with chronic UTIs post-menopause with vaginal estrogen. And this is another thing, it's interesting you say people are afraid of pregnant patients. People are also afraid of breast cancer patients, including the patients themselves. And, with the exception of perhaps somebody on a aromatase inhibitor, where we're actively trying to suppress all production of estrogen and then giving estrogen back, pretty much there's almost no, and you can, offer your opinion on this as well, but almost no contraindications to vaginal estrogen in postmenopause. And so, it's really, I consider it preventative care, although we don't have guidelines to recommend that as of yet. It's something everybody should be aware of that is safe and accessible.
No, I absolutely agree. I think it's an individualized decision per patient when it comes to using vaginal estrogen, especially for breast cancer patients. Like I think, patients without breast cancer, you can use it if they're having symptoms. But when patients have history of breast cancer or they're actively on treatment, I feel like somebody with, let's say, like stage 3 breast cancer, I'll be really concerned using vaginal estrogen. There are other, like lubricants that they can use. There are other procedures sometimes that are helpful. But if someone has like history of stage 1 breast cancer, they have finished their treatment, they're 10 years out, I usually let them use it. I do tell them use it maybe like 2 or 3 times a week and maybe for a short period of duration, not forever.
Yeah, go ahead, please.
And just to comment, we do have studies that there's many different preparations of vaginal estrogen, most of which have not shown systemic absorption. The cream can absorb slightly. But, I think for all of this, everybody has to remember, in yourselves and in our patients is, risk versus quality of life. So if somebody is extremely symptomatic, which for example, I had a patient that had metastatic breast cancer on, just treatment to, suppress, palliative treatment. And she had she was not even sexually active and she was day to day suffering from her vagina, just discomfort. And I gave that patient vaginal estrogen. So yeah, I think it has to be always, we have to weigh quality of life
Yes.
versus risk of cancer itself.
Yes, and I think that this is an opportunity that, we as a scientist have to address that, that question from like, using models of risk, and then we can include, a treatment like that, different compositions, and see what happens to the breast there as to inform, because, you know, we as a clinical practice, you look at the patients and the outcomes, right? Which are many. It depends on how your body responded to treatment, your type of breast cancer, how active you are physically, your metabolism. So it's a lot, to the point that, like, do you guys know that women were excluded from clinical trials for medication for many, many years because we are just too complex, right? Aspirin, we take the same dose that was optimized for men to use.
1993 that we were.
Not that long ago, right? And if you can only imagine how cancer care or even menopause care can have all those different variations, and it is very individualized. And it's fascinating to me as well. And I'm happy that we are having the discussion, because like I have like all of those different ideas that we, from a basic science perspective and breast health perspective, we can decide, we can address. Would animals that have BRCA mutations have different response to vaginal cream than animals that do not? What kind of change? What should we be looking for? Can that inform how that is beneficial or not for women in general? Do we have any more questions? Awesome.
Given the fact that rates of breast cancer are rising in younger people, is there a thought as to whether this is environmental or lifestyle or what might be driving that?
I'm not sure if we know, but in the last 10 years, there has been increase in younger people getting breast and colorectal cancers. So not just breast. So it's definitely environmental. I think the risk of getting breast cancer under age 30 is around 1%. So it's really, really low, but under age 40 is around 4 to 5%. It's not very high, but the risk overall, we feel like, has gone up in the last 10 years.
Certainly obesity is a risk factor for both of those cancers. So that could be, but it's always hard to tease out epidemiologic data like that.
And just from a scientific geek perspective here, so, the microbiome that we have in our guts circulate through our body, and breast has a microbiome as well. So we have a population of microbes that live in the breast, and at a normal balance, they are beneficial, very similar to what is in our gut. But you change that by diet, by obesity, by, not, helping the metabolism of your body. It can switch, the balance between good bacteria, bad bacteria. The bad bacteria will then influence the immune cells that you have in your breast, and they're controlling those cells that have tiny mutations to maybe start growing more. So it's everything is very, very linked.
Good morning, everyone. I have a question about dense breasts. It just, what do you do about that? If you have a increased risk of breast cancer from dense breasts, how does lifestyle, how can you change that? How can you improve that?
That's a great question. And again, that's why we have our program, breast wellness program at Northwell. So when you go for a mammogram and you are told on the mammogram report that you have dense breasts, there are two things you can do. One, you can have increased imaging surveillance. So you can have mammogram, sonogram. In addition, you can get breast MRI if you qualify for that. Having a dense breast and some of the risk factors most likely will make you qualify for getting a annual MRI. So that's one thing you can do to sort of like have more imaging and, diagnose cancer early on. The other of course, is lifestyle changes. So limiting alcohol consumptions, doing more exercise, healthy diet. Those are some of the things you can do to decrease your breast cancer risk.
And all of those are safe in pregnancy as well.
Absolutely.
Yes.
That was actually a good comment you made, Dr. Comfort. We recently had a case where we felt like the whole team was really afraid of the pregnant patient with cancer, and we had to really advocate for that patient. And I think that's why our program is so important, for cancer and pregnancy. I feel like every young patient, especially who is pregnant with cancer, should be treated with the optimal treatments that we have available so that they can have a good prognosis.
And before I let you, Adrienne, the complication with breast density during pregnancy, it's much stronger, right? Because as your breasts prepare to make milk, that on a mammogram could be seen as density increase. And one of the problems with breasts that are dense, it's not only that increases, the collagen and the fibers, it makes the cell grow faster, but it can mask very little lesions. The early lesions, they're hard to see. So we have a program with pregnancy and cancer to develop markers that we can detect in the blood of pregnant women to use it as a screening for breast cancer development, because pregnant women, they are not, unless you have a family history, you're not eligible for mammograms. You're not sent to do mammograms, not eligible, as normally as women that are not. So, and even if they do, there's all the composition of the breast that is changing that could be masking. So looking for liquid biopsies, right? What we can do in the urine, what you can do in the blood, are now, raising as great opportunities to monitor cancer development in pregnant women. But I wanted you to comment
I
on.
was just going to comment. Yeah. So breast density is more prevalent younger, right? As we age, especially post-menopause, the density tends to decline. You're not necessarily going to come out of dense breasts altogether, but sometimes you can. Hormones increase breast density. So if you're on hormone therapy, not that I would recommend coming off just for that reason, but it can increase breast density. And personally, I always recommend a sonogram alongside the mammogram for patients with dense breasts, as like you said, it can hinder detection. Not everyone will qualify for an MRI, but the way you can find this out, you should always ask both at the radiology facility that you're seeing and your doctor to see if they can calculate a risk score. There's two types of risk score. One is called the Tyrer-Cuzick risk. And the other is the Gale model. The Gale model, you can actually look up yourself online and calculate that. The Tyrer-Cuzick is more of a complicated calculation, but it's, it would be always good to ask your physicians about that risk score.
I've recently read some gynecological reports that say that caffeine can increase your risk of cysts in the breast. And I was just wondering about the correlation between the cyst, caffeine, and even soy. And I would love to speak, I know sugar and alcohol and to avoid those things, but I'd love to hear about that. And thank you, by the way, for all your information is amazing.
I love caffeine.
Breast pain.
So I'm not too sure about breast cancer risk and caffeine, but everything in moderation, I feel like, is always appropriate. Soy has plant estrogen. It is not same as external estrogen. I feel like soy, even in patients who have breast cancer, is safe if it is used in moderation. So not every day, but if you're going out and having a little edamame or something, I think that's safe.
There's actually been some studies on those who, or populations that eat more soy have lower risk of breast cancer. Whether
Yes.
that's directly related or confounding factors is unclear, but I think, I wouldn't necessarily say you should be taking soy supplements, but as part of the healthy diet, I think it's probably perfectly fine.
That's actually a very great point. Yes, it's the research done on communities that have higher soy income, it shows that they have a decreased risk on developing breast cancer. Parts of here has to do with the microbiome of the breast, not necessarily with like the estrogens that are coming down or up, at least from those reports. But absolutely. we have a question here.
Yes, thank you for taking my question. I'm a dense breast and I was taking mammography with the sonogram, and 6 months later I was doing the MRI. It's a certain age that they stop doing the MRI, because I was told this year that I don't have to do the MRI anymore. But why? If I was doing it for years?
Could have been that, and I hate this because it makes no sense in my opinion, but
Exactly.
so your lifetime, they go by your lifetime risk score. And so as we age, the chances, they go by like how how long you're probably going to live long. I think it should be like a 1-year risk calculator in my opinion, but they are usually using a lifetime risk calculator. And so the older you get, just by the nature of aging, that technically that risk goes down. So by insurance, you may have qualified out. I know.
But I know women older than me that they develop breast cancer.
Absolutely. And the risk of breast cancer goes up with age. So to me, it makes no sense, but that's our insurance-based system for you.
And I think that this is why conversations like that are important too, because we as women we're put it ourselves to be our best advocate, right? So I had my doctor that, helped me deliver both of my children, but it got to a point that the conversation changed, because I was like, I'm suffering from all of those perimenopausal symptoms, but there was no empathy for what I was going through. So I walk away from somebody that I was working with for 15 years, right? To be able to find somebody that when I walk into the office, they were like, okay, you have 8 options. And I'm like, this is all I needed. Just tell them all. I actually walk into their office and I'm like, all right, take it all out. I don't need that. This didn't ever work properly anyway before. But the fact that you presented options, it makes you feel less lonely. And yet 8, maybe just one of those will work for you, but having somebody that has a clinical expertise, that knows what they're talking about from like treating many women, it's so important. So we always have to be at the stage of being our best advocates.
And you can always obtain second opinions. Your doctor, a good doctor, will always want you to get a second opinion and will always encourage that.
That's a great point. We have a question there.
Thank you. Thank you. And the question is for everyone in the panel. I'm an advocate with MBCC, and I'm also the president of Latina Sister Support Inc. We support all type of cancer. 80% of our ladies are breast cancer survivors. I'm a 7-year breast cancer survivor. And my question is about BRCA testing and other mutations. And the question is, how important is for you to educate your patients or send your patients to be tested for that? And I'm asking that because breast cancer is increasing a lot in our community, especially the undeserved community, that they don't have this type of education. And this is what me as the president of the organization trying to bring to the community. And I think it's very important because we see within our sisters that their children are developing breast cancer, and they were never told to go for the BRCA testing or any other gene, mutation or any panel testing. So I think, I just wanted to know, like, how important is for all of you to ask your patient, to go for testing?
So by the time someone is diagnosed, I feel like it's too late to do genetic testing, but NCCN has actually widened the guidelines, and most of our patients with early breast cancer, as well as with stage 4 breast cancer, they qualify for BRCA testing and testing for other genes because there are medications specific to that population. So someone with the diagnosis of breast cancer, in most cases, they qualify. The bigger question is patients who don't yet have breast cancer, right? So for those patients who have family history, strong family history, or even with like 1 or 2 family members who have had not just breast cancer, but other cancers that are within that syndrome, like ovarian cancer, certain, skin cancers, GI cancers, etc. If they qualify for genetic testing, there are several ways of getting genetic testing done. They can get it done with their OBGYN practices or at our, in our program where we see these patients with high risk for breast cancer. In addition to imaging surveillance, we also offer genetic testing. And then we have a formal cancer genetics program at Northwell where we see patients who are family members of someone suffering with cancer. And, these family members, they are motivated to get tested, and they can easily get a test with either blood test or sometimes even the spit test. The testing itself is pretty easy. I feel like awareness is a more important topic here. They need to be aware that this is something that's easily available. In most cases, it is covered by insurance. Even if it is not, these days, I think genetic testing is relatively easy to get. It's not very expensive anymore.
Out of pocket's like $150.
Yeah.
Can I extend that question? So then, to Lizelle, so how do you see that from a patient that knows that they have a family history and they walk into your office and you're like, I'm pregnant?
Yeah. So pregnancy, I think, is a really unique snapshot and time point that as physicians, we sometimes take care of patients who otherwise don't see a doctor regularly. So we try to take an opportunity to take that family history. On the high risk end, thankfully, we have access to genetic counselors. We also have access to expanded carrier screening, which is a panel of a lot of genetic disorders that can detect some things, including like the RCA. I will say also, if somebody is a known carrier of a genetic predisposition to cancer, they can actually do like fertility treatments to select for future children that do not have that mutation. So I think that it's incredibly important to me to know whether patients have a BRCA mutation or a CHEK mutation or any type of predisposition to cancer. And I will say also, family history is something that we are not very good at taking as physicians. So from your end as an advocate, I think telling your patients to bring those things up if their physicians are not asking is very, very important.
Can I ask you a question? I'm just wondering how the stress factor in your life, if it's being studied by any of you, because the mind-body connection is extremely powerful. And I remember when I was in my 40s and I got a question, I was doing a holistic nursing program and they said, what about your stress level? And I don't have any stress. But of course, and certainly when that age, when you deal with your children and your jobs and everything else, you have a tremendous amount of stress. So I'm just wondering, where does that fit into your scientific program?
Yeah, so the research coming from Cold Spring Harbor showed that, the stress hormone that you have in our body is cortisol, right? And I think that my cortisol goes even higher when my doctor said, you have to decrease your stress. And I'm like, don't you think that I want that? And in the case of metastatic breast cancer, it was shown that elevated levels of cortisol can speed up metastatic disease and to a worse outcome that is not responsive to the treatments that are available for metastatic. From metastatic perspective, there's science being doing that. I can't speak for how that works in patients, but I agree with you. We are this whole thing and everything is connected. Maybe stress in the same way that alcohol in moderation doesn't do bad for you, but I can only imagine that, the factors when they come in together, it's all about windows of opportunities, right? Going through a traumatic part of your life is not going to be dictating you developing, cancer, but it's the collection of many years of everything that we're putting our body through that opens those window of opportunities that then the immune cells kind of like stop looking at the cells that have the potential to grow as cancer. It's wellness, right?
So big, I'm like half of my practice is like basically lifestyle medicine. And your question actually made me think of that as well. I mean, we know that essentially, let's start with metabolic disease, right, in general, is a risk factor for all of these age-related diseases, cancer, cardiovascular disease, dementia, et cetera. And yes, I mean, 9 out of the 10 factors that play into metabolic disease are within our control to change, right? I mean, clearly there's genetics play a huge role. Some of us need medications for various reasons, but you cannot, under stress the importance of daily exercise, movement. I love meditation. It's wonderful, but whatever works for you for stress reduction, totally agree with you. Diet is a huge, the crap that we eat today, that's a huge educational component, and it's a risk factor for all of this. It really is. And we don't know the exact right answer yet. We have sense of like where the direction it should be going, as far as the diet, but yeah, and sleep, all of these things play into the levels of inflammation in our body on a daily basis, which increase the risk for all of these diseases. So you're absolutely right.
I will say, I actually prescribe my patients medication in like the high risk pregnancy clinic. Sorry, meditation, not medication. Medication as well,
Medication,
but
so please.
meditation. It's free. So I think that in terms of patients coming from different access points, it is a great stress reliever. It can decrease blood pressure, can decrease, as you said, cardiovascular disease. So I think that it's something that is available to everyone in this room. It certainly is like a work in progress. I tell people that it takes practice. But I think that it's a great resource available to everyone.
Yeah, and you can access from this. You can access from any smartphone that you have. There are apps which, I listen to them. I'm not the kind of person that meditate with like eyes closed. I can't do that, but I like to listen and walk. And you can just, it is adapting to it as well.
And
We have a question there.
Sorry, just one last comment on this topic. So in addition to meditation, I think sweat it out is also important. Stress is, it's causing a lot of inflammation. And if you sweat it out with any form of like either, lifting weights or some sort of cardio that you can do, I think that's also very beneficial. If you do it, you'll notice after, like there is like this increase in heart rate, but when the heart rate goes down, you feel so relieved and relaxed. So that's another additional, exercise that would be helpful to manage stress.
I'm very happy to hear this whole thing on wellness, and we're talking prevention. And these are the things that we should be talking about. However, I work with NBCC and on a legislative level. And in the national federal research, if we think of it like a big pizza pie, the majority of that pie goes to better treatments, better drugs, etc. That pie that for prevention or looking into dormancy to keep it from coming back could barely be described as a sliver. So in all of our awareness and our pinkness and so forth, I think we better start opening our mouths that our taxpayers' money should be being used a little bit more for preventing this for us, as well as looking into dormancy. But this is our responsibility here, that we can do things, and we need to talk more about this too. So as usually, I have to put my 2 cents in, but I get very upset when I don't see things about dormancy, which is every woman's breast cancer survivor's worst nightmare, and prevention, and especially for those that have these genes that are frankly are knocking my family off like ducks in a row. And I'm very lucky to be here, and thank you for that research that keeps me here.
On behalf of Cold Spring Harbor and Pinkay, we are so happy to have you here. And finally, I know that we have a number of breast cancer survivors in this room, and maybe we could entice you to stand up and be acknowledged. I think one of our survivors, Sherry, would like to maybe make a closing statement.
Thank you very much. It is I who should be thanking all of you. But I do want to share just a brief part of my story. I am finishing the second part of my life. I will be 82 in January. When I was 41, I had a 2.5 centimeter tumor removed from my right breast, not left breast. I don't know how that happened. And it was very scary. I had 2 young children. I had a life. I was a swimmer. One of my doctors said, "Oh, we'll just give you a mastectomy." And I'm thinking of my bathing suit sitting there. And I was lucky enough to find very quickly a wonderful physician who did the lumpectomy, closed me up, and it was followed by weeks of radiation, during which I played tennis and did all my stuff. And I think if you have a patient who is young or any age, I think it's appropriate to give them hope. I have experienced the birth of 5 grandchildren. I'm going to the eldest one's wedding in 2 weeks. I have had a 41-year life and another 41-year life. And I'm hoping that it goes on, but it's in many ways thanks to all of you who do this wonderful research. Thank you.